Remember to press record. Okay, let's get started. I need to just make sure that I can see if there are new people who want in or some latecomers. And I will also tell you that there will be time for Q&A, and the chat is the place to put your questions or comments, but I probably won't see them or look at them while I'm speaking. But it's okay for you to type in there as we go through tonight, because you might forget later, or you just want to get it out there. Sometimes other people comment as well. That's all welcome. But I think we're going to have enough time tonight to make sure that we get through all your questions. So just letting a couple more people through. Welcome, everyone. I'm so glad that you're here. I'm just letting a few more people through the waiting room. And let's just say we get started at 5 past the hour. So I'm going to go 2 more minutes, if that's okay. Amazing. Amazing. I got to tell you, I hesitated whether or not to do this in the middle of summer, the middle of July. And then I just realized, you know what? Our health is too important not to. There is no such thing as a month for menopause. It's every day, every week, every month of the year. So I really appreciate that you're here. And if it's not heat that we're complaining of, it's usually the cold. So how long is the session, Mia? So it is being recorded, and you'll get a copy of the replay tomorrow. I think, I mean, I'm here for as long as it takes. I think it'll be under 2 hours, but it's going to be over 1 hour. And I'll explain that when we get started. But what I would remind you of is that if you have to jump off or you can't stay for the full time, to fast forward tomorrow when you get the replay, and then you can break it up into 2 sessions that way. All right, let's go. I won't see the chat, and I am just going to close that off, and we are good to go. Welcome, everyone, to the Menopause Chicks Masterclass. I called it the All Access Masterclass because what we're doing today in this session is combining the Masterclass and the hormone therapy FAQ, frequently asked questions, into one session. But it's all access because next Wednesday at the same time, I will be hosting the Vagina Dialogues, which is about 45 minutes, but it's all things genitourinary health. So I hope that you will join us for that. It's always good for Q&A as well, and really information that is not commonly discussed. Even though there are lots of conversations happening around menopause right now, still lots of questions and answers, more importantly, answers that you need and deserve in order to prioritize your health. So let's get started. Are you ready? Are you ready to put your own name at the top of the to-do list? Because that is one of my favorite phrases. And one of the ways that we one of the ways that we do that is through learning opportunities like this, which we may have never had. This might be the first health class that you've had in a very long time, but this is so important because we are the first generation to turn 50 and to have 50 more years, 5 more decades to plan for. So therefore, it is never too early, and it is never too late to invest in our hormone, our heart, brain, bone, and genital urinary health. But I will start out by saying that all these conversations that we're hearing in the menopause space, in the media, they might not yet be working. And that's because conversations or more conversations don't work if all they do is to continue to perpetuate outdated myths and misinformation. So our first challenge is not to learn necessarily, but you might walk away from tonight's session realizing, oh, my first challenge is that I have to unlearn what I maybe thought was true about women's health, about midlife health, and particularly about navigating perimenopause to menopause to postmenopause. For those of you that don't know, my name is Shirley Weir. I'm the founder of Menopause Chicks. I'm 57 years old. I reached menopause when I was 49. I started my own personal research journey in my early 40s, probably around age 41. And I launched Menopause Chicks onto the world stage in 2012. But I thought it was going to be a blog off the side of my desk, a little gift to my friends, if you will. And I quickly realized that I had discovered something, and that was the lack of community, the lack of clarity, the extreme amount of confusion and conflicting information. And so here I stand with you 12 years later, and Menopause Chicks is my full-time job. I have a certificate in peer counseling. I've invested heavily in women's health research over the last 12 years. And I specialize in knowledge transfer. So taking research information from verified sources like the North American Menopause Society, the International Menopause Society, and the Society of International Gynecologists, where I do a lot of online training. And I take that information and I bring it to you, hopefully in a way that is easy for you to digest, because the ultimate goal is for you to then feel informed and confident as you're making the health decisions that are right for you. Today's agenda is going to tackle the quality health information part. I am around in the Menopause Chicks community to help you build your health team if that is something that you need. And I usually start by helping you work with the healthcare practitioners that you currently have, because I've discovered that is the shortest distance between 2 points. But I also recommend that we consider building a bigger team to support our health. And then, of course, a community that has your back, and that is the Menopause Chicks community, or menopausechickscommunity.com if you're not already a member. The second half of tonight's discussion is going to be around frequently asked questions about hormone therapy and approved non-hormone therapy as well. And then, as I mentioned, the Vagina Dialogues is next Wednesday at the same time. So here's tonight's agenda in yellow: quality health information, FAQ on hormone therapy and non-hormone therapy, and your questions. So there will be a time set aside for your questions at the end. You can type them into the chat at any time. I will stay until the end. You will get a copy of the replay tomorrow. You are welcome to fast forward. You're also welcome to take the replay, watch it, rewatch it, keep it forever, share it with the people that you love, including your doctor, if that makes sense for you, or you'll probably take snippets of it into your next health conversation. It is yours. Okay, we have a little task to do first. I forgot to grab a Post-it note myself. Okay, I hope that none of your steering wheels look like this, but if you can, if you're in a place right now where you can grab a Post-it note, any color, any size, I want you to write these 5 words on your Post-it note. And this is such an important place to start. And oh yeah, by the way, this is not a class in staying positive. I mean, obviously I want that, but that's not it, but it definitely is. I added a word here. it is a class in staying curious about our health. And that will become more clear as we get through today's conversation. So grab your Post-it note and then write these 5 words. Please, I deserve to feel amazing. It might be the first time you've written that phrase, and that's okay. But I want you to take this Post-it note and place it where you're going to see it every day. Front of your refrigerator, bathroom mirror, office cubicle, wherever works best for you. And then take a picture of it and send it to me or post it in the community, because we have to begin with the end in mind. And if you might be like thousands or millions of other people coming to a conversation about menopause today and thinking all about symptoms, all about suffering, doom and gloom, I do want to change your mind, and I love to use appreciative inquiry. And so this is how we are beginning with the end in mind. It's that we all deserve to feel amazing. Now, I can't say that without also recognizing that sometimes the path towards destination amazing runs through a tiny little place, hopefully tiny, called not yet amazing. But that's okay, because I'm going to be your tour guide. And we are going to get through it. Here is a general timeline and definitions, and that's where I want to start off for the next few minutes. So in the middle, menopause is 1 day. It's the 12-month anniversary of our very last period, or it might be the day that a woman has both her ovaries surgically removed. The average age of menopause in North America is still reported at 51.2, but honestly, I don't think that has been checked in many years. And I hear from women in the Menopause Chicks community who are 56, 57, 58, 59. So I predict that it might be skewing older, but that's only anecdotal. I was 49 when I reached menopause. It has absolutely nothing to do with how old your mother was. It has to do with hormone production, and we're going to talk about that. The phase of life leading up to menopause is called perimenopause. And perimenopause is a word that was coined in 1996. So I think everyone on this call tonight remembers 1996, and it probably feels not that long ago. Perimenopause doesn't have a lot of research because it is so new and because women's health is under-researched. But the reason that we need to know about perimenopause is peri means around. It means it's that phase of life leading up to menopause, which is the end of reproduction, the end of ovulation, the end of menstruation. So if you think about a 10-year-old or an 11-year-old girl who doesn't have her period yet, that could be peri-puberty, okay? Her body is preparing for ovulation. And then at the other end of the hormone teeter-totter is perimenopause, where your body is preparing for the end of ovulation. And then after we reach menopause, sorry, I just got to let somebody else through here. After we reach menopause, we are in post-menopause every day for the rest of our lives. And that's an important definition to emphasize, especially if you're talking to other people, because I will often hear individuals say something like, oh, been there, done that, Shirley. I don't need to come to your masterclass. And it's not like a door that we walk through, but we're actually entering into 3 to 5 decades of life where we no longer produce the hormones that our body relied upon during our reproductive years. So it's really important that we use the right terms: perimenopause, menopause, and postmenopause. Now, this may look like a busy chart on your screen, but let me explain. I have put these phases underneath an umbrella because you will hear the word menopause used as I just described it, 1 day, and you will hear it described as an umbrella term, like menopause chicks for example, is using the word menopause as an umbrella term because I talk to women of all ages, every age and stage. So underneath this umbrella, on the left, we have perimenopause, and we do go through perimenopause. It's not forever. It's quite nuanced. It's not defined by symptoms. It's not defined by suffering. Not everyone has symptoms, but everyone will experience a decline in progesterone, which happens first, and fluctuating estrogen. And sometimes those two things will lead to symptoms. So generally speaking, progesterone is lower and estrogen will be high or higher. And while not everyone experiences symptoms, as progesterone does continue its decline, the most common experiences might be changes to mood, changes to sleep, and changes to bleeding. And then in the middle, we reach menopause. So I don't say going through menopause, I say we reach it. And it is a day, it's a milestone on the reproductive calendar that marks our end of reproduction. As I mentioned, 12 months after our final period or the surgical removal of ovaries. Why 12 months? Well, it's also a nuanced definition. It's something that just happened to be agreed upon by a team of doctors that they think that the ovaries will no longer develop an egg follicle. So you never know when your last period is your last period, but if you wait 12 months, then it's thought to that the individual is no longer going to reproduce. Then we're in postmenopause. So now I'm on the right-hand side of the screen, and we are in postmenopause for the rest of our lives. So I'm 57. I reached menopause when I was 49. I have been in postmenopause for 8 years. I will be in postmenopause for the rest of my life. What happens in postmenopause? Well, after we reach menopause, remember I said progesterone was already starting to decline before we got there. Estrogen joins it. So two hormones that we became very reliant upon for our health and reproduction are no longer at the same levels that they once were. Now, what does that mean exactly? You're probably thinking, or you might be thinking, end of period, sign me up. No more birth control, sign me up. I can't wait to get there. Well, what we're going to talk about today is the importance of understanding the roles and responsibilities of those hormones so that we can plan. I don't know if my finger is going the right way on the screen. I think I'll do it this way. Okay, so we can plan before we get there. And if estrogen and progesterone are two of the hormones that contribute to our vitality, our heart health, our bone health, our brain health, our vaginal health, our pelvic health, and our bladder health, I am on a mission to make sure that we don't get to the end of our 50s or the end of our 60s or the end of our 70s and find out that, holy cow, our body needs something. What does it need? No one told me that we need to take care of our hormone health in order to optimize all of those healths in that list. I'm not going to get into this too much tonight. I am a big word nerd. You've already probably heard there's certain things that I really like to say in a certain way. My reason for that, the why part, is because I believe that language and words and interpretation of certain words are getting in the way of women accessing healthcare, the healthcare that they need and deserve. And so I'll give you some statistics, but I'm not going to get into a lot of the words that I don't say or that I do say. They'll come up throughout the evening. Here's why. In a study from a few years ago, it's called inherwords.ca, conducted here in the province of British Columbia, it showed that over 50% of women in my age demographic leave our health appointments feeling dismissed or disappointed. And the top two reasons for those health appointments were menstruation and menopause. If we are leaving our health appointments feeling dismissed or disappointed, it is very natural for us to think, oh, the doctors must suck. The doctors are bad. We need different doctors. We need new doctors. And while some of that may actually be true, there's another element to that. And that is we have never been taught how to show up for our doctor's appointments or doctor's conversations, and we've never been taught how to advocate for our own health. So that is why I am such a word nerd. And the second reason why I'm not going to get into this too much tonight is I am writing a new book. It's called Speaking of Menopause, and its only intention is to close that gap, to make sure that women everywhere can show up both confident and informed for their next health appointment. So let's talk about hormones and roles and responsibilities. Now we're going to talk about roles and responsibilities of hormones when our cycles are regular. And the reason that we're doing that is because we need to make a plan for ourselves when hormones are no longer regular. So I don't know if you know this or not. I mean, what's a hormone? It's very nuanced. It's very, I don't know, kind of magical, but yet if you look at a magazine cover or you use Dr. Google, you see hormones being used in all these different kinds of ways. And so this is how I like to explain hormones, because they're not tangible. It's hard for us to reach out and touch our hormones and turn them up or turn them down. So hormones are like text messages. They're a message that starts in our brain, in the pituitary gland. And what we're talking about mostly tonight, estrogen and progesterone, although I'll touch on a few others. The pituitary gland is sending a text message to our ovaries saying, hey, I think it's time to develop an egg follicle. Can you take care of that, please? And the ovary, depending on the age and stage of the woman, responds accordingly. So hopefully that is an analogy that works for you, or that maybe helps you explain when you're talking to others. Because if you think back to the last health class that you were at, it probably looked a little like this. Maybe it was grade 6, maybe it was grade 7. But most of us were taught first how a baby was made, and then we were taught how not to make a baby. And well, for me, that was the end of health class. No one ever talked to me about the names of body parts, the roles and responsibilities of hormones. And certainly I didn't get any information or education along the way about how to prepare for, wait for it, 5 decades of my life. So we're going to do that tonight. I don't know why I put this in here, because I just love looking at the picture of the female reproductive system. I think that was meant to go next to the text message. So it's like the message coming from the brain, going to the ovaries, asking them to develop an egg follicle, taking care of our overall reproductive cycle. Now we're going to talk about the roles and responsibilities of our hormones when cycles are regular. And you are sitting there thinking, what the heck is a watermelon doing on the screen? Well, the first hormone I want to talk about is estrogen. And estrogen does get a lot of airplay in women's health. Estrogen is the first hormone to be released in the first 2 weeks of our cycle when cycles are regular. Estrogen is a really strong, feisty, powerful hormone. And you might know that or remember that as how you felt or feel in the first 2 weeks of your cycle. And it has to be feisty and strong because it's developing an egg follicle to send it on its journey, which is pretty amazing when you think about it. But the reason why I have the watermelon as the image for estrogen is that estrogen is also, I mean, it has many hundreds of roles and responsibilities, including taking care of our heart and our brain and our bones and developing the egg. It is also responsible for keeping our eyes moist, our mouth moist, our skin moist, our joints lubricated, and our vulvas and vaginas lubricated. And then in the second half of our cycle, oh, wait, why is there a figure skating picture here? Well, I am a fan of ice dancing and ballroom dancing, but the reason I put this picture up here is to represent progesterone. And progesterone is the hormone that's produced in the second half of our cycle when cycles are regular. And progesterone is the perfect dance partner for estrogen. It is calming. It is relaxing. It also has many roles and responsibilities, including protecting our brains and investing in our bone health and taking care of the uterus, the lining of the uterus. Progesterone also regulates bleeding when cycles are regular. But together in that second half of the cycle, progesterone just becomes this perfect in sync partner for estrogen during our reproductive years. I'm going to quickly touch base on some other hormones, but tomorrow when I send you the replay, if you don't already have this, it's a free link to read online in the Menopause Chicks community. There are expanded definitions and more hormones talked about in Feel Amazing. I can also include the link when I send the replay tomorrow. I do want to talk about testosterone because testosterone often gets misinterpreted as a male hormone and a sex hormone. And it is those things, but women also make testosterone as well. And the reason I've got the strong woman here is that while testosterone plays a role in our sexual health, it is also, and I don't know if you know this or not, it is responsible for our confidence. And I love to talk about confidence a lot. We can get into testosterone therapy questions. I can't take many because testosterone therapy is not approved for women in North America, but we can get into that in the Q&A. I just really wanted to focus on roles and responsibilities here and testosterone being an important female hormone and responsible for our confidence. Now, another hormone that's really essential for women to know about and learn about is cortisol. Cortisol is our stress hormone, and you may even be able to relate to the individual on this screen, but cortisol stress, although we need a certain level of stress, it is also an influential player in the production of estrogen and progesterone by our ovaries. So stress out of control can impact the production of those hormones and therefore impact our ovulation cycle. Anyone that's dealt with infertility might already know this. Just really essential that we know about this and that we, more importantly, know what things we can do to complete the stress cycle and keep that under control. Thyroid might be the most under-discussed hormone when it comes to women's health. Thyroid, super important. Have a conversation with your doctor at least once a year about your thyroid health. Thyroid is responsible for, it's our internal furnace. It's responsible for our metabolism, and it's easy to have it checked with your healthcare team. So super important. It also, there are many things as we're navigating perimenopause to menopause to postmenopause, many experiences, many adverse health experiences that get tossed into a bucket and get labeled menopause. And I'm a huge advocate for actually no, not everything belongs in a bucket labeled menopause. It's either related to estrogen, related to progesterone, or it might be related to something else. And more often than not, it is related to a thyroid condition. So please do put this on your list and ask your doctor to check it with you. I like visuals, and so you've heard me say so far tonight about estrogen being the first hormone to decline and estrogen to fluctuate and then decline in postmenopause. I thought that I would draw it out for you here because you might be visual too. So estrogen is the purple line. It's estriadol, actually. It's one of 3 kinds of estrogen that, that we make. And as you can see, it fluctuates. See the purple line fluctuating on the left in puberty, but not as much as it's going to fluctuate in perimenopause. And of course, everyone is different. This is just a snapshot as a teaching tool, but look at how normal and regular estradiol is during this middle big section, our reproductive years. While progesterone does a very slow ride up, it is like a bit of a roller coaster hill, and then starts to decline before we even enter perimenopause. And when that happens, you can see how the green line is crossing down while the purple line still remains high. And so we were used to progesterone being high and estrogen being lower. And in perimenopause, again, this is only generally speaking, it's almost as if the two flip. And usually that is the reason why somebody would experience symptoms, although not everyone is going to be symptomatic. So the red line is represented by symptoms going up while these two hormones are doing a fluctuation and or decline. And then on the right-hand side, you can see my concern, and why I want everyone to be aware of this is that we have this long part of our life called postmenopause without the estrogen and progesterone production that we were once used to. And the arrows just kind of point to where the symptoms are probably going to be the most intense. Another way to illustrate this would be a roller coaster where estrogen is at the top, but progesterone is at the bottom. And these next few slides, we're going to walk through what are the most common experiences when this happens. So in perimenopause, common experiences associated with low progesterone and estrogen fluctuating might include irregular or heavy bleeding. Our period may get shorter, longer, lighter, and for 70% of women, it may get heavier. We might notice changes to sexual desire, breast tenderness, mood and sleep are two biggies. Sometimes foggy thinking, which was definitely my experience, but now as I look in the rearview mirror, I think cortisol was playing even a bigger role. PMS is premenstrual syndrome. You might experience that maybe for the first time. You've had your period for decades, but now you're in perimenopause and you're experiencing PMS. Sometimes you might experience feelings of anxiety or feelings of it's not depression, depressed feelings is what I want to say. I am a word nerd. So it's not a diagnosis of an anxiety disorder or depression, which is equally important to have investigated, but you might, for the first time in your life, be experiencing feelings of anxiety and depression. And the last thing on this list, which arguably could be first, is vasomotor symptoms. Vasomotor symptoms is the correct word for hot flashes and night sweats. Vasomotor means that the arteries that is carrying the blood are dilating. That's the root cause of a hot flash or a night sweat. And why is that happening? It's the decline in two major hormones, either progesterone or progesterone and estrogen. The majority of vasomotor symptoms are experienced in the final 1 to 2 years of perimenopause. So you could still have a period. Maybe you've started noticing changes to your period and have vasomotor symptoms. And this is kind of contrary to the interpretation that we often get from media, is that, oh, I'm not there yet, so this can't be a vasomotor symptom. This can't be a hot flash, which in fact, what I'm saying is, yeah, it most likely is, and it certainly can be. And sometimes vasomotor symptoms will go away, but what I want to leave you with tonight is I want you to rethink how you consider vasomotor symptoms. I hope you start to regard them as a tap on the shoulder or a brick to the side of the head, or as a check engine light that comes on in your car. When the check engine light comes on in our vehicles, we pull over to the side of the road, we lift the hood and we investigate. And vasomotor symptoms are a check engine light. It's like an invitation to say, whoa, Shirley, things are changing and your future health is really important for you to investigate and to invest in at this point in your life. Oops, sorry. And then after we have gone 12 consecutive period-free months, or if someone has their ovary surgically removed at any time, that is the day of menopause. And what's important about that day? Well, I think it can be celebrated. There's a lot to celebrate about the second half of life, including newfound wisdom and confidence. I changed careers. I know lots of women who changed careers and changed partners and changed where they live and changed what they love to do with their free time and all of those good things. But there's a couple other things besides celebration that I want to leave you with today. And one is contraception or birth control. So really what we're talking about, menopause sort of has this conversation that happens over here in a big way about how all the ways women can suffer. But the reality is that menopause means the end of ovulation and reproduction. And so you're probably making, if you haven't already, decisions about contraception. So here's what the International Menopause Society recommends. If you are under the age of 50 and you reach menopause, you should continue contraception for 2 more years. The reason for that is that there may still be another egg follicle that is going to be developed, especially if you are under the age of 50. I heard a doctor speak about this at the International Menopause Society conference when it was here in Vancouver a few years ago. And really, you could hear it in this doctor's voice where he's like, I do not want my 50-year-old patients to get pregnant. And most 50-year-olds that I know do not want to get pregnant either. So under the age of 50, continue contraception for 2 more years. If you're over the age of 50 when you reach menopause, continue contraception for 1 more year. And then the last thing on the list is let's develop an investment strategy. If we've reached menopause, imagine this was like RSP day, or retirement savings day, if you're in the United States, where it's like, oh, I sit down today and I make an investment plan for my next 3 to 5 decades. Then you are in postmenopause. And the reason I have a cliff diver here is because that decline of estrogen that I was talking about on the green line and purple line chart, it happens like that. It's quite dramatic. It's quite sudden. And that can have an impact to our quality of life now and for future years. So the experiences that are most common in postmenopause include dryness. Goodbye, watermelon. Often it's hello, new dryness with our skin. Maybe the products that we use don't work as well as they once did. Maybe our hair is a lot drier. Our joints may be creakier or more sore. We can't do the same types. We have to change up our exercise routine. And the drop in estrogen, as well as hyaluronic acid, which I'll talk about more in next Wednesday's Vagina Dialogues, but it really impacts our pelvic floor. It directly impacts the vulva health, the health of our vulva, the health of our vagina, and the health of the urethra. And the urethra gets shorter and smaller without estrogen, and that can make it more susceptible to infections. And the most common type of infection for women in postmenopause is frequent or reoccurring UTIs, which stands for urinary tract infections. The loss of estrogen also can impact our bladder health and the overall pelvic floor. So many women will experience incontinence and pelvic floor prolapse. So, hey, estrogen was doing a really important job before menopause, and now we have some decisions to make if we want to enjoy that same quality of health in postmenopause. The other thing that I've included on this list is difficulty remembering, and for some women, continued vasomotor symptoms. So remember I said vasomotor symptoms, hot flashes and night sweats, can happen for the majority in the last couple of years of perimenopause, but for some, they continue for 5, 7, even 10 years longer. So you would never leave the check engine light on in your car for 5 or 7 or 10 years. So I don't want you to ignore vasomotor symptoms because you don't want even more damage to be caused to your car. You certainly don't want to risk not prioritizing your heart, your brain, your bone, and your genitourinary health for the next 50 years. Okay. This is a pyramid that I created, and it's on page 25 of my book. And I want to walk you through it because the reason I created the pyramid is when we're talking about common experiences of hormone fluctuation and decline, more often than not, it is going to lead to a conversation about hormone therapy. Now you'll notice on this inverted pyramid that I created that I've put hormone therapy at the bottom. And that is not because it is the least important. The reason it's at the bottom of this pyramid is because I do not want women skipping to the bottom to hormone therapy thinking, voila, that's the magic wand and all will be well, because that's not always going to be the case. And so I created the pyramid as a way for us to ask questions about what the root cause might be. And this could very well be a discussion tool or part of the script tips that you create for your next health appointment with your doctor, where you can explore, oh, is my brain fog related to how I've been eating lately, or my lack of exercise, or my sleep, or my insomnia? Do I have insomnia? So the first level is lifestyle related. And of course, we could do like a whole class on just this pyramid. So I'm going to go really, really fast, but it's important that we understand and ask questions about, is it related to how we eat, move, and sleep? Is it related to stress? Am I missing something nutritionally? And in terms of supplementing or asking questions about nutrition, these are probably the 4 or 5 that I talk about the most: iron, magnesium, omega-3, and vitamin D. Is it related to something else? Now, I've put the word thyroid into this pyramid, but this could be any other health condition. So if you are going through this list and you're asking a question about, why am I losing hair? Well, is it going to be related to lifestyle? Maybe, I don't know. Stress could be, but I wouldn't stop there. I wouldn't just say, oh, it must be stress, I'm stressed out, and continue to lose hair, because hair loss is an important tap on the shoulder to help us get, what's the word? Curious about what the root cause is. Now, I might get to nutritional support and learn that one of the symptoms of iron deficiency is hair loss. But a symptom of thyroid is also hair loss. And so I need to work with my healthcare professional to figure out, do I need to test my ferritin? Yes, you do. Do I need to supplement my iron? That will be determined by the level that your ferritin is at. Or do you have a thyroid condition that might be able to be managed with medication, lifestyle adjustments that you and your team come up with together? And then it might not, you might not be at an age and stage where hormone therapy is appropriate, or it's not even related to hormone therapy, but you might want to be having an investigative or a curious conversation with your doctor about what the potential benefits of hormone therapy might be for you. Let me say that again in just a slightly different way. My job, although I will always share with you my personal journey and the hormone therapy that I take and what I have learned along the way, my job is not to convince anyone to take hormone therapy. My job is to convince all of you to have a curious conversation or an investigative conversation with your healthcare team about what the potential benefits might be for you. So please keep that in mind as we go through, because we are going to move into the hormone therapy FAQ, and I will explain it the best that I can, but ultimately it is up to you to be able to decide if this is part of your investment strategy as you move forward. And it's important because what if we have more of these investigative conversations and we significantly decrease future rates of heart disease and stroke, which is the number one premature reason why a woman dies. In Canada, it's every 22 minutes a woman dies of heart disease, and that can be prevented. What if we could significantly turn down rates of dementia? And while dementia affects both men and women, it affects more women than men. And what if we could significantly decrease rates of osteoporosis? And we're going to talk about bone loss in a minute, but you need to know that 1 in 3 of us in our generation is going to fall and break a bone due to osteoporosis. Now, that's a line from the Osteoporosis Society, but here is what I have recently learned. Remember, I'm a word nerd, and I really like to say things the right way. You know how we always kind of refer, or you've heard the phrase like grandma fell and broke her hip? Well, here's what we need to know about bone loss. Most of the time, grandma's hip fractures first, and then she falls. I want you to take that in, because in the first 5 to 6 years of postmenopause, we lose 20%, approximately 20% of our bone mass. Now, the way to protect our bone health is three-pronged. It can be through nutrition, combined with strength building exercises, and hormone therapy is approved for the prevention of bone loss. So I like to, well, I don't lift a lot of weights, but I'm really, really focused. That is my thing to learn how to do and to really emphasize this year, because I want to be able to hit the mark on all 3 corners of that 3-pronged approach for my bone health. Vaginal dryness and atrophy. Atrophy means when a muscle shrinks in size. It will be experienced by all of us if we live long enough, and reoccurring UTIs are responsible for 10.5 million doctor visits per year in North America, about 10 million in the US, about 500,000 here in Canada. Think about the doctor appointments that we could open up if we knew, and I can share that with you next week in the Vagina Dialogues, if we all knew and we all told our mothers and our sisters how to prevent reoccurring UTIs. And incontinence is the number 2 reason why a woman is admitted to long-term care. So let's get to work and turn down the dial and significantly decrease these statistics for our own health, as well as for all the women that we love. Okay, so it's 10 minutes to the hour. I would like to keep pushing through, if that's okay with you. I might have a sip of water. And go through the second half of tonight's masterclass, which is hormone therapy, frequently asked questions, and I'm going to touch on the non-hormone therapy information that we have as well from the North American Menopause Society. And the reason I want to push through is because I find that most of the time Q&A is related to hormone therapy. So this is going to set the stage, and then I will spend the remainder of our time together going into the chat and answering your questions. So I hope that's okay with you. Okay, so I do get a lot of questions about hormone therapy. As I said in the first half of the class, it is not my job to tell anyone to take hormone therapy, but it is my job to make sure that women are having curious conversations about what the benefits might be for them. Why do I have a Rubik's Cube on this slide? Well, hormone therapy is very individualized. And so it needs to, it needs that personal conversation and assessment with a trusted health professional, but it's also not a one and done. It's not like, oh, I need a Band-Aid, I put it on and I'm good. It might work that way for you, but most often, and most of the women in the stories that I hear, it requires tweaks. And of course it does, because we're all individuals. We're all at a different age and stage. We all have different experiences. And think about the Rubik's Cube. I don't know how to solve a Rubik's Cube, but imagine I could, and I could get, oh, the blue side. I could get it all blue. And let's just say that that is restoring my estrogen and progesterone health. And then I turn the cube over and I'm like, wait a second, it's all mixed up still. There's red with white and yellow with orange, and it's not solved. And that's because it's not just about our hormone health. There's usually other things happening at the same time, such as very busy, stressful lives, and such as life, like grief and divorce and work and all of those things. So I use the Rubik's Cube as a symbol for when we're talking about hormone therapy. I also have another umbrella slide for you. Hormone therapy is an umbrella term. So you'll notice that I usually say hormone therapy. I do not say HRT, which stands for hormone replacement therapy, because most of the time when I'm talking about hormone therapy, it's for women close to or in postmenopause. So you're not actually replacing or restoring hormone levels to the levels that they were when you used to develop an egg follicle every month, but you are receiving a hormone-based therapy that's going to give you, fewer or mitigate symptoms and higher quality of life. And we'll talk about menopause hormone therapy in a second, but back to the umbrella. So it's an umbrella term because underneath the umbrella are a lot of things. And this is where misinterpretation, especially over the last 20, 30 years, has really wreaked havoc on women's health, period, but also their ability to access the healthcare that we need and deserve. So on the left-hand side are forms of hormone therapy. You may not have thought of it this way, but the birth control pill, the IUD, progesterone therapy on its own for maybe somebody who has PCOS or, well, quite frankly, needs it. Or even tamoxifen, which is a drug that is developed to treat certain types of breast cancer, is a form of hormone therapy. And then on the right-hand side of the screen is what the North American Menopause Society refers to as menopause hormone therapy. And that is a protocol that's developed between you and your doctor using the guidelines from the North American Menopause Society to determine whether or not you are getting the right hormones at the right dose via the right mode of delivery for you. So I'm going to unpack that in a second. We'll talk about mode of delivery. And more often than not, that is going to include estriol and progesterone, and then a form of vaginal hormone therapy. And what is menopause hormone therapy approved for? Well, it's approved for the treatment of hot flashes, night sweats, or the right term, which is vasomotor symptoms, the treatment of what the North American Menopause Society now refers to as genitourinary syndrome of menopause. Okay, I can say genitourinary, but I don't love syndrome of menopause. I love the word syndrome. And I don't even know a woman or a doctor who talks about genitourinary syndrome of menopause. They will most often report vulva and vaginal dryness, pain in pelvic floor, prolapse, like a pelvic organ prolapse, bladder, or uterus or rectal, and or atrophy, and they used to call urinary syndrome of menopause, vaginal atrophy. And they said that women didn't like the word atrophy. And so now they've come up with this new term, which makes it really a bit of a mouthful when I'm trying to explain it to someone. But hormone therapy is approved for keeping our genitourinary health at the top of the to-do list. And it's approved for the prevention of bone loss. Everything that I'm about to share with you in this FAQ section is from the North American Menopause Society most recent position statement. So they come out with a position statement on hormone therapy anytime there is something new to report. The most current edition is from 2022. You can go and find this, or your doctor can go and find this at menopause.org. I have probably read it over 1,000 times. I refer to it a lot, depending on the questions that I am investigating. And, I don't expect lay persons to read this position statement, but I do expect healthcare professionals to use this as a tool. Or here in Canada, the Canadian Medical Association came out just last year with a position paper itself that basically said the same thing, but it was like reinforcing that menopause therapy needs to be the first line investigation for women approaching the menopause transition or in post-menopause. So let's get to some questions. We're going to run through what it's approved for, some common words and questions that I get about what is bioidentical versus non-bioidentical. What does route of administration mean? What do I need to know about efficacy rates or how effective a certain therapy is going to be for me? What do I need to know about FDA or Health Canada approved hormone therapies versus compounding, which are non-FDA and Health Canada approved, and some of your most common questions. So hormone therapy or menopause hormone therapy is approved for the treatment of vasomotor symptoms. It's approved for the treatment of anything that falls under the genitourinary umbrella: vulva and vaginal dryness or atrophy, pain with penetrative sex, urinary tract infections that happen over and over, like more than once a year, and incontinence. And it's approved for the prevention of bone loss. And I'll just repeat an important point that I mentioned in the first half of the masterclass, which is when we reach menopause and estrogen and progesterone have both declined. Remember, I talked about the roles and responsibilities of those hormones when our cycles are regular. One of the roles I mentioned was protecting our bones. When those hormones have declined, we do lose bone mass. And it's quite dramatic in the first 5 to 6 years of postmenopause, up to approximately 20% of our bone mass. And hormone therapy is approved for the prevention of that bone mass. It's sometimes recommended that progesterone be used in perimenopause. That would probably depend on symptoms. It's going to depend on age and stage. And frequently it's used on its own. So you can take progesterone on its own before you start estrogen in postmenopause. Sometimes estrogen will be prescribed prior to menopause, and that's going to depend. Remember the colored lines, and I said, this is just a generally speaking snapshot. It could be that a woman hasn't yet reached 12 months, so she hasn't officially reached menopause, but maybe estrogen was doing this and it's already declined. And so that would be an example of when her and her healthcare provider would discuss whether or not it would be progesterone only or progesterone and estrogen as a protocol for her. The North American Menopause Society recommends that we start taking hormone therapy within 10 years of menopause or under the age of 60. That's because that is when it's going to have the greatest impact to our quality of life. And one of those reasons is the bone loss thing that I was just mentioning. So waiting till after we're 60 to have this conversation. By the way, this is a guideline. It's not a deadline. It's not like you're 59 and you can take it and the next day you turn 60 and you can't. It's not that. It's just that the efficacy rates are better if we start within this guideline. So that's something that often gets misinterpreted as well. And the second part about this guideline that often gets misinterpreted is what we are talking about is systemic hormone therapy, estrogen and progesterone that you would take either orally or transdermally. Nothing to do with this guideline of under 60 or within 10 years of menopause has to do with vaginal hormone therapy. If you qualify for vaginal hormone therapy, you can take it and has nothing to do with this guideline. And the third really important point on this slide is another common misinterpretation, and that is there is no time limit for how long we can stay on hormone therapy. The amount of time that you stay on hormone therapy is going to be a decision that you make via shared decision making with your healthcare provider, depending on your health and depending on how your discussion around do the benefits still outweigh the risks, or are there any risks? And so that's really important to emphasize. So again, all of this is relating to the conversation about systemic hormone therapy. It is really important that you understand this is an individualized protocol and one that requires all of us to have a benefit versus risk assessment. Now, a few years ago, we used to say, in order to start hormone therapy, you should have a personalized risk assessment. I'm so happy to see that the Menopause Society and other respectable societies and associations in this space are changing that language. Why is that important? Well, first of all, there's a risk to every therapy, and there is a risk to not choosing hormone therapy. So we do not want women to think, oh, it's too confusing, I can't go there. Of course, that doesn't apply to you because you showed up for this masterclass tonight. But if you think that you are doing yourself a favor by not getting informed or curious about what the potential benefits might be, there is a risk to not exploring hormone therapy for you. And the second thing I wanted to talk about there is that now we talk about an individualized benefits versus risk assessment. And that's important because often risk gets misinterpreted, right? It's like teeny tiny risk, but huge benefit to maybe giving your body back some of that estrogen and progesterone that it used to make on its own as a way of investing in heart, brain, bone, and genitourinary health. And yes, I'll just repeat this, but vaginal hormone therapy is should be available for everyone who needs it, which is usually women post-menopause. How are you doing? I hope you're doing okay. We don't have that many more slides to get through, but we're going to be okay for time and definitely under the 2-hour mark. Bioidentical versus non-bioidentical. Again, something that got a lot of misinterpretation over the last 20 and 30 years. I need to emphasize for you, there is no such thing as natural. Again, my word nerd coming in here, but there is no such thing as natural hormones. So except natural hormones are the ones made by the ovaries. So if your girlfriend tells you she's taking natural hormones, that's not true. She's likely taking bioidentical. Bioidentical doesn't mean natural. Bioidentical and non-bioidentical are terms. They might not be great ones, but they are terms that describe the molecular structure of a hormone therapy. And they're different. They have different responsibilities and different jobs to do. So the other thing that you need to take away from this is that bioidentical doesn't mean good and non-bioidentical means bad. It's not that at all. And that's why they are products that are both available on the market, it means that they have different jobs to do, and that there may be a reason why you and your healthcare professional are looking at one or the other or both. So I'll give you some examples of brand names in a second, sorry. What else did I want to tell you about that? Oh, yes. So bioidentical, maybe should have been called biosimilar, or kind of the same, or familiar, or recognizable a little bit. What it means is that the therapy, or the molecular structure of that therapy, is similar to the hormones that used to be made in the ovaries. And non-bioidentical is a molecular structure, not synthetic, because all hormone therapy is synthetic. Synthetic means made in a lab. So if you hear that non-bioidentical is synthetic hormones, that's also needs to be unpacked and clarified as well. Non-bioidentical hormone therapy, like the Mirena IUD or the birth control pill, they have a molecular structure with a certain job to do. And in those two cases that I just gave you, the reason they were designed is to prevent a pregnancy. Oh yeah, so here's some examples. So examples, these are common brand names for bioidentical hormone therapy or bioidentical menopause hormone therapy would include estrogel, which is a form of estradiol, but estrogel is the brand name. Another common name would be Divigel. Those are both creams or gels that you apply to the skin, but also can come in a patch form or combination form. And Prometrium is a name for bioidentical progesterone that is taken orally. And Vagifem is a brand name for bioidentical vaginal hormone therapy that's actually a suppository that you insert. Non-bioidentical would be the Mirena IUD, or probably every brand of birth control pill out there. So when we're not talking about bioidentical or non-bioidentical hormones, there's another word that makes its way into this conversation that sometimes gets confused with bioidentical. So these are bioidentical hormone examples that are made by reputable pharmaceutical companies. Okay, I've got samples here if anybody needs to see them. Compounding hormones are made by a compounding pharmacist, and believe it or not, most pharmacists are compounders. They can make things. So compounding really just means customizing. It means that if you can't take a medication a certain way, let's say it comes in a capsule, but you can't swallow a big capsule, like kind of like me, and you can ask your compounding pharmacist if they could make it into a liquid or a gummy or a gel or something. And sometimes they can, and sometimes they can't. So compounding just means customized. And for that reason, it's not FDA or Health Canada approved. So it's not the first line recommendation for hormone therapy. The first line recommendation is going to be what is Health Canada and FDA approved, because that's going to be the easiest, it's been studied the most, and compounding is going to be a tool, an option that's available if somebody needs something special. Route of administration is how we take it. So the ways that we can take hormone therapy include orally, transdermally via a cream, a gel, or a patch, vaginally, which would be a cream, a gel, a ring, or a suppository. And then other examples of a route of administration might be the IUD or pellets. Pellets are a form of hormone therapy where it's inserted under the skin. It is not FDA or Health Canada approved. So why or how would you be making these types of decisions? Well, how you take a hormone therapy is certainly not the first decision that you're going to bank. You're going to first be talking about what are the hormones that I need for my age and stage, and any symptoms or health goals that I currently have. what are the doses that I need, and that's completely up to your prescriber. They know what the doses are and how to tweak them if you need that. But the third decision to be made is, how do I take it? And the number one determining factor should be efficacy. So how effective is this going to be at mitigating my symptoms or protecting my health going forward? So I'll give you some examples. Estrogen is most often taken transdermally. So that would be with a gel, mine's a gel that you rub on your arm. That bypasses the liver, and it has the least amount of risk associated with blood clots as it relates to estrogen therapy. I think I have a slide on this coming up in a second. And progesterone, you take orally. And the reason that you want to take estrogen orally is because it has the highest efficacy rate for protecting the lining of the uterus. The second decision to make might be compliance. And this does not get enough discussion in the hormone therapy world. Do you ever wonder why there's so these package inserts that come with hormone therapy or any therapy that you might pick up at the pharmacy, and you read it and you're like, oh, I don't know, I can't make sense of all of this, but my doctor prescribed it. One of the reasons why those package inserts are the way that they are is that the pharmaceutical companies are protecting themselves legally. You get that, but why do they have to protect themselves legally? Do you want to know why? It's lack of patient compliance. So if we are not going to be compliant, meaning regular, take it as directed with our therapy, and like this could apply to hormone therapy or anything else, then it's not going to deliver the health outcome that was intended by you and your prescribing physician. So when it comes to hormone therapy, when you have options, you might think, you know what, there's no way I'm going to remember to put a gel on my arm twice a day, morning and night. That's not for me. But you might decide the patch is for you and that you only have to change it once a week. So that's an example of whatever works for you and your personal compliance. What's happening here? There we go. Oh yeah. So number one place to go is that if you are discussing estrogen as an option for you, you are going to want to talk about how you can take it transdermally because it has a safer risk profile than oral estrogen with respect to blood clots, stroke, and cholesterol changes. But some women still, like, oral is still available and on the market. So that's a conversation that you want to have with your prescriber. Progesterone, as I mentioned, oral micronized bioidentical progesterone, or common brand name is Prometrium, does have the highest efficacy rate for protecting the lining of the uterus. Some women do take oral progesterone and have an IUD because maybe heavy bleeding or fibroids has been part of their history. And so they need that combination. And that's where the discussion, the individualized discussion with your prescriber is so important. So what about progesterone cream? So progesterone cream is available over the counter in the United States and probably available on Amazon. And I say to you, do you want to take something that's not approved by the FDA or Health Canada, but also do you want to take a hormone therapy that is going to influence your health, that is not guided by a hormone expert? And personally, and my hope for all of you is that you do not do it yourself. This is not a DIY project. This is something that is very important to your health. Do not go to over-the-counter progesterone cream on your own. If it's being guided by your healthcare professional, maybe, but only after you have discussed the benefits versus risks of taking oral bioidentical progesterone. Okay, we're almost there. Are there exceptions? Yes, there are. Are there combination treatments? Yes, there are. I mentioned patch earlier. There's also combination patches that include estriadol and a progestin. Progestin is the non-bioidentical form of progesterone. And then I get this a lot too, actually. Can you take progesterone orally, estriadol transdermally, and still need vaginal hormone therapy? And the answer is yes. And these are all mine. What is recommended for treatments as it relates to genitourinary syndrome of menopause or vulva and vaginal dryness, atrophy, reoccurring UTIs? Well, what you need to know here is that there is no timeline. So it's not like, oh, I'm over 60, it's too late for me. That's not the case. It is not too late to start a vaginal hormone therapy. The options include cream, gel, ring, suppository. They're all applied locally. Estrogen is very common as a vaginal hormone therapy treatment, but there are some new things that have been introduced, probably been in the States for years, but two new things to Canada. DHEA or prasterone. The brand name is Intra-Rosa. So it's DHEA that's once it's applied to the vagina, it converts to the estrogen and testosterone that our body needs. Please don't ask me how that happens. But that's what I know about Intra-Rosa, and it was brought to Canada in 2022, fall of 2022. So still quite new, but definitely something that you could explore with your healthcare provider when you're making decisions about vaginal health. And there is an oral treatment called Osphena so that you can take orally. And this would probably, for, individuals have different preferences, but this might be part of a compliance decision or discussion that you're having, that if you take all your vitamins in the morning and, you fall asleep quickly at night and you always forget to apply your vaginal hormone therapy, that maybe taking something orally might be a good option for you. So lots of new things happening in women's health. I want to go over what hormone therapy prevention questions I get. So we talked about how estrogen protects the heart when our cycles are regular. Hormone therapy is not yet approved for the prevention of heart disease. There's a very complex answer to that, and there has been a lot of discussion for more than 30 years around the relationship between hormone therapy and heart health. But you can imagine the resistance, because you wouldn't want to give a woman, when heart disease is so prevalent in women, and it's the #1 premature reason why women die in this country, you wouldn't want to give women hormone therapy and then say, oh, now you're good, you won't get heart disease, because that's not the message. So that's why hormone therapy is not approved for preventing heart disease, but it will, when we are on hormone therapy, contribute to other things. So remember I said how hormone therapy is approved for 3 things, but that doesn't mean it doesn't have other benefits, such as supporting our sleep and supporting our mood and hopefully protecting our heart in some way. Brain health or preventing dementia, it is not approved for that, but that we know that estrogen and progesterone does protect the brain when cycles are regular. Breast health, I'm going to talk about that for a quick second if I can. Maybe I'll leave that to the Q&A. I do have a scenario around understanding the risk or unpacking the risk of hormone therapy versus breast cancer if you're interested. But there's check marks beside bone health and vaginal and pelvic health. And so hormone therapy is approved for the prevention of bone loss. It won't treat it or reverse bone loss, but it can stop or help stop future bone loss. And then with vaginal pelvic health, with the right protocol, you can prevent and reverse vulva and vaginal dryness and atrophy. Okay, how's everybody doing? What should we be asking about breast cancer? I think this is really important, so I'm going to do it very, very quickly. I'm not going to give it the energy that it deserves, but we can then take the discussion into the Q&A. This is important, and maybe you haven't heard this before. 1 in 8 of us will get breast cancer if we live to be 85. That is the global statistic. If we are less than the age of 85 today, our risk is less. But what doesn't get talked about in terms of risks associated with breast cancer are these things. And I would like to bring that forward today. First of all, do I have breasts? Yes. So I do have a risk for breast cancer. We all do if we have breasts. Is my age a factor? Yes, it is. What age category am I in? And these are questions, this is a type of dialogue you're going to be having with your health care provider. So is my age a risk factor for, I mean, if I'm 82, my risk is almost at the top of the curve for getting breast cancer. But what about other things that are modifiable? They're called modifiable risk factors. And those include exercise, my weight, obesity is a risk factor for breast cancer. It includes genetics, which is very individualized. But do I have a first-degree family member who had or has breast cancer? That needs to be part of the discussion. And last, but certainly not least, is what is my alcohol consumption? Because alcohol consumption in women is a risk factor for breast cancer, and it does not get enough airplay. And it certainly doesn't get the same airplay that breast cancer risk for hormone therapy has received over the last 30 years. So we have to check that and actually consider pursuing a no or low alcohol lifestyle. This is directly from the North American Menopause Society position statement on hormone therapy. And what it tells us is that, first of all, this is not the numbers that I'm going to throw out in the next minute or two. And I know we've been at this for a long time, but they're really important. These numbers are not your risk for getting breast cancer. What we're talking about is the incidence rate, the number of times a case of breast cancer comes up while using hormone therapy, and we do not know the other risk factors. We do not know the exact age, we do not know the alcohol use, we do not know the other modifiable factors. But the risk of breast cancer related to hormone therapy use is low, with estimates indicating that a rare occurrence, less than 1 case per 1,000 women. Okay, so women should be counseled about the risk of breast cancer with hormone therapy, putting this data together. Another way of saying that would be women should not be dismissed by a lazy or uneducated or uninformed or a healthcare professional who's lacking curiosity just because there is a rare occurrence of breast cancer while on hormone therapy. Everything needs to be taken into consideration, weighing the benefits of her current quality of life and her future heart, brain, bone, and genitourinary health with any known risk factors. So what does this look like when we tease out the numbers? Well, 1 out of 1,000, and sorry, I put an asterisk here because when we're talking about counseling women about the risk of breast cancer and putting that data into perspective, we have to make sure that we're highlighting that modifiable risk factors includes daily alcohol. And I did a session with Dr. Balpawa a couple years ago on alcohol use, and she described an experience with one of her patients who was so hesitant to start hormone therapy, but she was going through her intake form, and she's like, "Oh, and so tell me, like, what is your alcohol use?" And the woman said, "Oh, no, not very much at all. I only have a couple of glasses of wine every night with dinner." And so Dr. Pawa wrote down 14. 2 glasses of wine every night with dinner is 14 glasses or servings of alcohol per week. And the woman was like, "Oh my God, I have 14 a week. I never even thought of that. I pour one while I'm making dinner and I have another one while I'm sitting down." And so putting this data into perspective for women as it relates to hormone therapy risks and benefits, it's just super important that we underscore. And I don't think enough of us know how to interpret our own personal risk. We certainly shouldn't be doing it on our own. I don't know that enough healthcare professionals have the desire or the time. They certainly don't have the time to go to this level of explanation with all of their patients. So what happens if you're on hormone therapy and you stay on it for 5 years? I've been on it a little bit longer than that. Well, here's what the North American Menopause Society states. When a woman is on hormone therapy for 5 years, the estimates indicate still a rare occurrence of an additional 3 cases, 3 additional cases per 1,000 women. So it was 1 case and now it's 3. So 3 out of 1,000. And I know when you hear those numbers, you think, well, hopefully not me, right? Because we all go through the world with our fingers crossed, hoping it's not us. But what does that actually mean? So remember, this is incidence of breast cancer, not your risk, but 3 out of 1,000 is 0.003%. So that's less than 1/3 of 1%. Plus, remember I said we don't know the other factors in her life, such as alcohol use, but she is 5 years older. And age is a risk factor for breast cancer. So all of those things need to be put into context. And if you're making decisions because of a very, 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 very small rare occurrence of breast cancer, but you're living with chronic vasomotor symptoms and vaginal atrophy and bone loss, where 1 in 3 of us, 33% of us, are going to fall and break a bone due to osteoporosis, those 2 things really need to be appropriately weighed. And so I like to put it into something that maybe we can all relate to, because I know that those numbers just sometimes don't land for everyone. So we were talking about how if a woman is on hormone therapy for 5 years, the increased rate of occurrence of breast cancer could be 3 out of 1,000, which is 0.003. So how do most of us get to our doctor's appointments? Well, we usually drive our cars there. So I'm like, okay, well, what is the chance of being killed in a motor vehicle accident? And Google told me that the chance of getting killed in a motor vehicle accident is 1 in 101. Well, I'm not a mathematician, so I can't even compare 1 in 101 to 3 out of 1,000, but I can do percentages. So 1 out of 101 is 0.009. Now, the good news is that's still less than 1%. And it's probably why none of us are afraid to hop in our car and drive to our doctor's appointments. But it's 3 times higher than the rate of breast cancer occurrence when a woman is on hormone therapy for 5 years or more. So what we really need to do is have more conversations about risk and benefits versus the real risk to you. It has to be individualized. These decisions need to be made via shared decision making with your health team. You do have to consider your quality of life. I know many breast cancer survivors who come to me and they're like, I've been through hell already. I just want to feel well now. So quality of life is going to be an individual decision. Vaginal health, future bone health, current and future bone health, and any side effect benefits such as supporting sleep, supporting mood, all of those things that we talked about in the beginning. Are there any existing health conditions? Do I have anything existing that needs to be worked into this conversation? I'm lucky I do not. Are there any things that I can modify to help mitigate risk? Yes, there are. I can, exercise. I can cut out or cut down alcohol. And so, and the final bullet point here is, what is the real risk to my health for the next 3 to 5 decades if I don't take hormone therapy? A couple more slides. If I'm on hormone therapy and I do not yet feel amazing, we have to remember the Rubik's Cube. Come back to the Rubik's Cube and these 4 questions. Am I taking the right hormones for my age and stage? Am I taking the right doses for my age and stage? Am I using the mode of delivery that has the best efficacy rate for me? And when should I book my next review appointment? I'm going to skip this, but these are some examples of other questions that women have submitted. I'm ready for your questions. I also have a couple more. Oh, I didn't do the non-hormone therapy. I don't know where those slides went. I promised non-hormone therapy. So in 2023, the North American Menopause Society released a position statement on the approved treatments for approved non-hormone therapy treatments for vasomotor symptoms. So this is a key point that you need to know if you're considering or you have a contraindication for hormone therapy and you're looking at non-hormone therapy options. They are approved for the treatment of vasomotor symptoms. They do not address the bone health element, and they do not address the genitourinary element, but that should not be a barrier for you, because you should qualify for vaginal hormone therapy. If you've had breast cancer, if you have breast cancer risk, whatever has prevented you from not starting hormone therapy, you could probably still explore the benefits of vaginal hormone therapy. When we look at that list, they evaluated everything from supplements, yoga, cognitive behavior therapy. Not a lot made the approved list. What did make it are FDA and Health Canada approved medications that are prescribed in what is called an off-label format. So that means you're getting a prescription for something other than what it was originally designed for. And probably one of the most common examples of that in the menopause space is antidepressants being prescribed for the treatment of vasomotor symptoms, and those are still on the list. So we have physicians, prescribers have access to these therapies that might have been originally intended to treat depression or anxiety, and they have an off-label benefit of reducing vasomotor symptoms. They do not treat the root cause of the vasomotor symptoms, and you already know that because we've talked about it tonight, the root cause being the decline of estrogen and progesterone. So my message to you, obviously, is to get curious and to choose and make the health decisions that are right for you, but make sure that you understand and can have a more informed conversation with your healthcare provider about what is going to be right for you. And I have included a couple of slides here with script tips. So if anybody needs script tips, you can reach out to me after. We can create a personalized version of this for you for when you go to your next health appointment. So I'm going to close this down and get into the chat because I want to see what questions you have. And I really want to thank you for your patience and for sticking this out. This is amazing. Absolutely amazing. I think there's over 200 that registered for tonight. I know many of you might be watching this on the replay. It's getting warm in here, so I just totally appreciate you, and I need to get to the top of the question list. So let's do this and grab a sip of water. As I mentioned, I will stay, and if you have to drop off, you can always get the replay tomorrow and fast forward to the Q&A. Okay. Okay. Can you speak to the options for women who are progesterone sensitive? Also, can you summarize the use of testosterone? How would it typically be determined if testosterone supplementation is indicated? Okay. Progesterone sensitive, I don't know a ton about, but I know I speak with a lot of women who use that phrase. So first of all, oral micronized bioidentical progesterone is encased in peanut oil. So if you are allergic to nuts or have a nut sensitivity, that might be something that is not going to work for you for obvious reasons. The other thing is back to that slide that I had with the 4 questions. So you might think that you are having a reaction to progesterone, but it might not be prescribed at the right dose for you. So that's something to explore. Progesterone is approved for up to 300 milligrams. So one of these is 100 milligrams, but it's approved for up to 300 for the treatment of vasomotor symptoms. If you're taking 100 and you don't yet feel well, or you're not getting some of those side benefits of progesterone, such as supportive of our mood and our sleep, or mitigating bleeding, then it might require a dosage change, or it might require something else. You might do better on a progestin. For example, if you are trying to treat bleeding or fibroids, maybe you need localized progestin in the form of an IUD. So it's going to be very individual. And then if that's like, there's lots of things on the menu, and I love to make sure that you show up at your health appointment knowing and understanding everything on the menu, so that you can go through all of the options with your prescriber and kind of do a pros and cons list. The other option that's available to you is compounded progesterone. So a reputable compounding pharmacy could make progesterone for you, and you'd have to find out if that is the right, in the right dose, depending on your goals, depending on your symptoms and your health goals. Can you summarize the use of testosterone? Yeah, very quickly. So the International Menopause Society, years ago, like maybe 5 years ago, put out a position paper for testosterone therapy for women. Testosterone therapy for women is not yet approved in North America, but that doesn't mean that a prescriber can't prescribe it for you. Not a lot of physicians have experience doing that because it's not approved for women, but we like society does off-label prescribing all the time. So I think it is something that we can learn if women do need testosterone therapy. Why might you need it? Well, the common experiences associated with testosterone decline are on page 14 to 16 in my book. So it might be sexually related, it might be something else. And that's really for you and your prescriber to work on together, and then decide what the options are available to you and what the doses would be. How would it typically be determined? Yeah, hopefully I just answered that. It would be determined probably through your symptoms. I had a partial hysterectomy at 39. Okay, so just to clarify that, a hysterectomy means the removal of the uterus. And so you don't partially remove the uterus, you remove it all. So a hysterectomy is the removal of the uterus, and an oophorectomy, OOPH, oophorectomy is the removal of the ovaries. I had a partial hysterectomy at 39. I began having hot flashes at 47. I am now 55 and still have hot flashes constantly. It is my understanding they may never end. This breaks my heart. Yeah, you know what breaks my heart is that nobody prepared you with a conversation about hormone therapy, but I'm here tonight to tell you that it's not too late for you. So I hope you got some great content tonight, so that and you feel more confident and informed to go to your healthcare professional, because you are not meant to suffer. You deserve to feel amazing, and your body is asking for something. Vasomotor symptoms are an invitation. It's asking for you to stop and pay attention and to get the appropriate treatment for that, because it's going to have all of these other side benefits of giving your body back a little bit of what it used to make on its own. I was told that I don't need progesterone because I have my ovaries, probably like raisins. And my doc says I don't need testosterone either, so only doing estrogen patch. Okay, so that's still the same person saying that. Okay, so this is very common, and I'm glad that you brought this up, because I don't think we exactly went through this in the hormone therapy FAQ. You can take progesterone on its own, but you cannot take estrogen on its own if you have a uterus. And the reason for that is estrogen cannot go unopposed. It has to have that dance partner to balance it out. especially if you have a uterus, because the uterine lining will grow. So because of that, we have this long-standing prescribing protocol that says, oh, well, if she doesn't have a uterus anymore, she doesn't need progesterone. And I push back on that big time. I was trained by Dr. Jerry Lynn Pryor, who is like the world's guru. She's 81 years old this year on progesterone research. And to say that a woman doesn't need progesterone is to say that the only, sorry, let me start again. To say that a woman doesn't need progesterone if she doesn't have a uterus is to say that the only role of progesterone is to protect the lining of the uterus. And that's not true. Progesterone supports our mood and our sleep. It invests in our brain and our bones, and it regulates bleeding and protects the lining of the uterus if we have one. So I can help you have a conversation, or we can work through an example of those script tips on how you can have approach your doctor about progesterone if that is something that you want to pursue. Otherwise, your current protocol is healthy and safe because you can take estrogen without progesterone if you don't have a uterus. My hair is falling out nonstop. I can handle it. I think you mean I can't handle it anymore. I have done all the testing and everything is fine. Well, it's not fine because your hair is falling out. And that burns my butt when women get told that they are suffering and fine in the same sentence. Doesn't make sense. And no, it's not. Okay, you're with me. And they're telling you it's stress, and it's not stress. Okay. Angela, hair loss is really, really common. So the number one root cause for hair loss that I encounter is women who are iron deficient. And the first thing, have your ferritin level checked. Hair loss can start when ferritin falls below 60. A woman will not be diagnosed as anemic unless ferritin is below 20, below 25. But that doesn't mean that your ferritin level is optimal. So there's a difference between a diagnosis of being anemic and having optimal ferritin levels, which in between those two stages, you can have a whole lot of debilitating experiences. Fatigue, exhaustion, hair loss are probably the most common, but it might include brittle, dry nails, pale skin, pale lining of the eyes. You can pull your eye down and see and tell if you might be iron deficient, but it's best if you go and ask your doctor to write a requisition to have your ferritin tested. And if it is below 60, which I'm gonna guess it might be, then to supplement with a quality iron. If your iron and your ferritin is fine, I'll use the word that your practitioner used, then you have to continue to get curious. So you have to work your way through the pyramid, which is on page 25, and say, okay, I've checked if I'm deficient in any nutrition or nutrition. I don't need a nutritional supplement. Do I have another health condition? Have I had my thyroid checked? Because hair loss, fatigue, and exhaustion can also be a sign of a thyroid condition. So please look at that. And the third thing I want to say, and it's a bit of a pivot for me, because I used to stop there. And in the Menopause Chicks community, there will always be somebody who wants to recommend a topical solution. They multi-level marketing, they have the magic wand for hair loss. I have been looking into hair loss products over the last few years, and the pivot that I've had is that if someone is losing their hair, that is impacting their quality of life, and it's impacting their confidence, and it could be impacting a whole bunch of other things like what they do socially and their mental health. And so and this is what I recommend now, while you are investigating your iron, because I know that it'll take a while to get the appointment and the blood work and blah, blah, blah. And while you're investigating your thyroid health, look at what some of the research is showing for hair treatments for hair loss products. And I can help you with that too. I just don't want to get too detailed in it today, but I know that it's going to be really important if we can do those things together. Related to the question about progesterone sensitivity, are you aware of any reliable evidence that exists that supports the link between estrogen supplementation and the risk of uterine thickening, potentially increasing cancer risk? I'm wondering about the evidence supporting the current progesterone prescribing guidelines. So I need to interpret this a little bit different. Yeah, there is research that shows that taking estrogen without progesterone is going to increase or thicken the lining of the uterus. I'm not a prescriber, so I can't talk about doses, but in terms of making sure that you have the right doses for your age, your stage, and your current symptoms, you need to take that question to your prescriber and make sure that you are getting the right dose for you. It's not a magic wand. It could be a Rubik's Cube. It could take tweaking. Often progesterone is started out by prescribing at 100. And depending on what your symptoms are or what your health goals are, for example, if you're dealing with very heavy bleeding and fibroids, like my best friend was a few years ago, she started with the maximum dose, 300 progesterone, and got an IUD. So everyone is going to be different, but I'm not quite sure about the evidence. If you want to reach out to me privately and continue that conversation, I would be happy to. I had a uterine ablation at 44. So now that I'm 49, I'm feeling very unsure of how and when I will reach menopause, as I haven't had a period since the procedure. Thank you for bringing up ablation. It is one of the options for anyone who's experiencing heavy bleeding. It will fix the bleeding. It doesn't fix the root cause of what caused the bleeding, which was progesterone decline. But yeah, I see that you're sort of in this age range where you're like, I don't know. So really it's about look at the pyramid and say, how can I, like, and reverse engineer it? How can I continue to eat, move, prioritize sleep as best as I possibly can? And how can I manage my stress? And then look at page 14 to 16 in here, which will describe for you what some of the common experiences are associated with progesterone decline, estrogen decline, and other things like cortisol and thyroid. And if you're currently having symptoms or debilitating quality of life, match that up and make that part of your dialogue with your healthcare provider. Not having a period is probably, going to make it more difficult for you to get curious, but not impossible to get curious about where you are, nor does it matter. You might be in a place where you're like, you know what? I'm experiencing this, this, and this. So I am going to go and have a curious conversation about the potential benefits of hormone therapy for me right now. I'm not going to wait. So that it really, really is going to depend. And they did a prolapse repair at the same time. I understand. I hope that you also have a pelvic floor physiotherapist on your team, because even having pelvic floor repair or pelvic floor surgery, I don't want you to have it twice. And so if you don't have a pelvic floor physiotherapist, I highly, highly recommend that you work with one so that you can continue to optimize pelvic floor health and that you don't have to have another surgery. Dermatologists and gynecologists dismiss you all the time. So frustrating for sure. Yeah, I understand. I mean, I gave you the statistic from the In Her Words study, and it's true. And medical gaslighting is true. But I also think that we have such a broken or inappropriate system for what midlife women need right now. And that is, we can't even graduate enough doctors to take care of this very important demographic. And then we graduate them, the ones that we do graduate, we put them into a model that rewards 10-minute doctor's appointments. And we've been here tonight for 2 hours. So that should sort of help to set the context of what our physicians are dealing with themselves, let alone, a mountain of student debt that they have and trying to make sure that they can pay their assistants. Like, it's a lot. And then when we show up and we're not able to present our knowledge, like hopefully you gained here tonight, and an understanding or to be able to articulate what our desired health outcomes are or we want them to be, it makes it more difficult for them. And then there might be all sorts of other things baked into that as well. I'm seeing some comments hidden and I don't know why or how I get them to see them. But if you're recommending products on here, I need everyone on this call and those watching the replay that they're not an endorsement from Menopause Chicks because I don't know what's hidden. Okay, for thyroid, would you recommend only testing TSH or adding T3 and T4? I would recommend a full thyroid panel if that's at all possible for you. My ND, so my naturopathic doctor, wrote the section on thyroid in here, so you can hear about that from her. Her name is Kathleen Mahana, but if you don't have an ND on your team or that's not a resource that you can access, start with T1 and T2 with your doctor because it might provide some insights, right? So having blood work done as it relates to thyroid or anything else with our health team, it's really like confirming or denying a hypothesis. If T1 and T2 comes back and it's just fine, but your ferritin is low and that's something that you can treat, at least you've started the process. And if you want to go full, have a full thyroid panel, probably working with a naturopathic doctor would be the shortest distance between 2 points for you. And there are so many great naturopathic doctors. I'm not sure if you're in Canada or not, but 30% of Menopause Society certified practitioners, 30% of them in Canada are naturopathic doctors. So there's really been an increase in not only their investment in menopause education, but also they have prescribing rights in Ontario and British Columbia, but also their approach to integrated healthcare for women. So they work really well with your family doctor. We all can't be specialists in everything. So if you can have a health team, then work with your family physician on what they can do for you with regards to thyroid health, and then add someone like another expert to your team if you can. If using vaginal estrogen only, how do I get the health benefits that estrogen and progesterone give if I'm not taking it? You don't. You would have to take systemic estrogen and progesterone to get the other health benefits. So localized means it only works where it's applied. So I've used localized a couple of times tonight. One is to describe like an IUD, which is localized progestin therapy to the lining of the uterus. And localized vaginal hormone therapy is localized estrogen or DHEA to the vagina. I brought this as an example because this is a cream. And the reason I love it is because it doesn't ignore the vulva. So the skin cells outside and inside are super important. I love this chart. Thank you. I don't know what chart you're looking at, but you're welcome. I love charts too. This is a great picture. I am so perimenopause right now and all the symptoms that I have. Oh boy, all of the above. My periods have gotten shorter at 47. I also felt being calm was much harder. I asked my doctor for progesterone and it came back in the normal range. I don't know if it was a blood test that you did or not, but you do not determine your hormone levels through blood work. The reason for that is that hormones are always fluctuating, especially at 47 in perimenopause. And so whatever tests that you had done, it's only a snapshot in time. Your level of progesterone, which was being tested, would have been higher or lower that morning, that night, last week, last month. It changes constantly. So if you need progesterone, it is better to set the stage by using your age, your stage, which is your date of last period, and what symptoms you are experiencing. And you can find that on page 14 to 16. So that could be related to mood, sleep, irregular bleeding, so on. What causes scanty and short periods? Irregular bleeding. So I don't know what causes short periods or longer periods, but I can tell you what causes irregular bleeding. And that is the height, the distance between estrogen, which is that purple line that was fluctuating quite wildly in perimenopause, and progesterone, which has already started its decline. Can you be in the normal range, but it not be normal for you? Yeah, so I don't even talk about normal range of progesterone because normal is only on that chart when we are in our reproductive years. Okay, so that was the green line that kind of did the little bit of a mountain. That's normal, but you're in perimenopause. So there really is no normal. The most predictable thing about perimenopause is its unpredictability, and bleeding definitely falls into that category. So I'm sorry if that was confusing, that you had your progesterone checked and it came back as normal. I would want to revisit that using age, stage, date of last period, and what your primary symptoms or health concerns are, and then see what hormone therapy is going to be best for you. And it might definitely be progesterone. And then you have options. It might be oral progesterone, it might be an IUD, depending on what your particular situation is. Missed some info. Period still 28 days, also having insulin sensitivity, which is related to progesterone. It sounds like you might have, I don't know, reach out to me if I didn't answer that one fully for you. Can you be in perimenopause and have some postmenopause symptoms? Yes, absolutely. Great question, Angela. Because it allows me this opportunity to clarify something. They are not symptoms of perimenopause. They are not symptoms of postmenopause. Perimenopause, puberty, postmenopause are life stages. They're not diseases or ailments or conditions. So what you're experiencing are symptoms of progesterone decline, estrogen fluctuation, if you're in perimenopause, or estrogen decline in perimenopause because estrogen is doing this. It's doing the fluctuating, and it might be fluctuating wildly, which is causing symptoms of like what I put up on the screen for postmenopause, which was dryness. So it might be like a real noticeable change to dryness in all the parts, or maybe it's a memory thing. As I search for words, I'm talking about memory, loss of words. So yeah, check out page 14 to 16 of Feel Amazing and see how it matches up to your experiences. I have been on daily progesterone for 5 years. I started at the age of 43 in perimenopause. I figure I must be in menopause now. I am very interested in balancing hormones for a family history of menopause. So we don't actually balance our hormones. They decline, and then we give our body back a little bit of what they used to make on their own to mitigate symptoms and to invest in our quality of health. And I figured it's time to explore estrogen. I have been referred to a menopause expert, but I think it may take time to get an appointment. I am considering booking with my family doctor, who is not knowledgeable about postmenopause, to discuss starting estrogen. In the meantime, I am wondering how to begin the conversation and what to ask for transdermal estrogen, which would be the best time to start and at what dose to begin with. Okay, so you started at 43 and you've been on it for 5 years. So you're 48 years old and you think you might be in menopause now. I assume you still have a uterus. And so, sorry, I am interested in estrogen for a family history of osteoporosis. Gotcha. Thank you. That makes sense now. Okay, so I can't quite tell if you have a uterus to know if you are have reached menopause, but you definitely, same thing as I said to the last member, your age, your stage, date of last period, and any symptoms that you're having or health goals, and you fall directly into the health goal category, is because you want to prevent osteoporosis. And the best way to prevent osteoporosis is hormone therapy as soon as you reach menopause, if not before, and you really want to mitigate that bone loss that happens in the first 5 to 6 years of postmenopause. I would guess that your doctor knows a little bit about that. And if he or she doesn't, One of the things that you could do, I mean, of course, I can provide you with script tips and kind of go into the appointment cold. But one of the things that you could do, if it's possible, is email ahead and say, Doctor, I have a concern about family history of osteoporosis. My mother, grandmother didn't have the advantages of hormone therapy. I'm interested in making sure that I'm checking off of the nutrition box, the strength building box, and the hormone therapy box. So I've set an appointment. I'm coming in on July, whatever, and I want to talk to you about the potential benefits of hormone therapy for me and my bone health. How's that sound? I bet you if you send that in advance and maybe the link to the position statement from the Menopause Society or whatever you think might be beneficial, or we can write out some script tips for you. In the US, they will typically start with the lowest dose and work up from there. I use the transdermal as well. I've not used progesterone because I was told I didn't need it because I still have my ovaries. It's the second time I've heard that. But Lord knows they are withered little raisins at this point. Okay, none of that is really actually, I don't know if that's true or not. I've not had any vaginal issues at all, and I like to believe it's related to having started estrogen immediately upon symptoms. Okay, that's a great segue into providing some clarity. So when we start systemic hormone therapy, it can have benefits for our vaginal health for a period of time. So what can happen, and when I say can, I mean me. So I started hormone therapy when I was 48, progesterone. I reached menopause at 49, added estradiol, and then I was like, wow, this is working great. I don't know. I mean, I feel for all the women that are experiencing vulva and vaginal dryness, but I'm not there yet. And I thought, well, it must be because I'm on hormone therapy. And then because estrogen goes for a steep decline and it never resumes, then I started to experience the symptoms related to my genitourinary health. And so then I added vaginal estrogen, and you might be in the same boat. And if you can, doesn't matter. It's not too late. You can be in prevention mode or treatment mode, but I love prevention. So if you have an opportunity to prevent, go for it. And we will talk more about that next Wednesday in the Vagina Dialogues. What I do is I explain all of the reasons, which is not just the menopause transition and the hormone fluctuations, but all the ways that can lead to vulva and vaginal dryness. And then I explain all the options for treatment and all the options for prevention at every age and stage. I have only been on combination hormone therapy for 2 weeks, estrogen and progesterone orally, but one of my main symptoms is extreme vaginal dryness and very painful intercourse. Should I be using vaginal estrogen to treat this and omit my combination hormone therapy? No. Keep your hormone therapy, I think. I mean, assuming, I don't know how old you are, but yes, keep it and add vaginal estrogen. Can it be used to treat menopause symptoms? Okay, there's no such thing as menopause symptoms. There's just symptoms associated with progesterone decline and symptoms associated with estrogen decline. So you can add vaginal hormone therapy and you can add a moisturizer with hyaluronic acid. And I hope that you'll come next Wednesday or watch the replay of the Vagina Dialogues. It's not as long as tonight. It's only going to be about 45 minutes, but it will go through all of your options and exactly answer what you need to know about hyaluronic acid decline as well as estrogen decline and how that relates to vaginal health. And I am just wanting to remind you that all of this is treatable. There are easy, viable solutions. So that should hopefully get you really excited. Bring your friends or share the replay with your friends. Nobody should have to suffer from vulva, vaginal dryness, or painful insertive sex. I am 8.5 years since my last period, tried hormone therapy 2 times within that time frame for about a year each time. Each time I had bloating, breast tenderness, so I stopped. Now my doctor feels I am too long post-menopause and she is not comfortable prescribing. Wow, double whammy right here. I'm only halfway through. So I understand there's a 10-year time frame that is quoted related to cardiac risk. Nope, not necessarily. What are the risks? Any thoughts on the type of estrogen that might not cause the bloating I have had in the past? Thoughts on testosterone as well for sexual arousal? Oh, okay, that's jam-packed. Let's see how I do. Anytime hormone therapy is prescribed and you do not yet feel amazing, I want you to think of the Rubik's Cube on my slides. It often needs to be tweaked. So you go back to your prescriber and you say, I'm doing well here in this and this. Let's say I'm sleeping and I don't have hot flashes anymore, but I'm experiencing breast tenderness and bloating. Breast tenderness is a sign that your hormone, that the dosing is not right, or the efficacy is not right for you. We are all so individual that maybe you were taking something transdermally and you weren't absorbing enough of it into your skin. Maybe you weren't compliant, I don't know, with the dosing. Something was off that needed attention. It requires a review. You don't start it and stop it. And I know you did, and I'm not trying to like shame you or chastise you for that. I just want everyone to get the same message, is that it's not one and done, but it requires tweaking, especially in the first little while, especially if you're still in perimenopause or it's your first time starting a therapy. It needs a review, hopefully within that first 8 to 12 weeks of starting it. And then if you're experiencing something that's still debilitating to your quality of life, then it gives your prescriber the opportunity to make sure that you're getting the right doses, the right hormones for your age and stage at the right doses, and the right mode of delivery for you. Why do you think there are so many modes of delivery? It's because not everything works for everyone. So we have to find out what's right for you. I don't know how old you are. So yes, there's a guideline for taking hormone therapy. And that guideline is designed to optimize the best time to prevent bone loss, for example. And so it shows that if a woman can start hormone therapy within 10 years of menopause or under the age of 60, that is going to have the best health outcomes. But if you are longer than 10 years since menopause, or you're over the age of 60, it's not a deadline. It just means that you need to present your health case a little bit differently. And that's one of the script tips I had. And it's on my website. It's at menopausechicks.com. If you go to the article about how to have a conversation about hormone therapy when you're over 60, just read that. That's all related to systemic hormone therapy. Vaginal hormone therapy is like slam dunk. You should be on it for the rest of your life. Thoughts on testosterone as well for sexual arousal. So, the studies show around sexual desire, which I understand is different from arousal. Sexual desire is actually probably rooted in cortisol, and that mindfulness and meditation is actually one of the best ways in which women can address issues with sexual desire. If it's a sexual dysfunction, then that should be a conversation that you have with your doctor, a gynecologist, someone who understands the roles of testosterone in a woman's sexual wellness. And then like we don't want to put a solution ahead of the problem. We want to make sure that we understand what the problem is, which you've articulated, what the root cause of the problem is, and then is testosterone on the menu of options for you? And I say, yes, it is. We're in this like place where it's not easy or available for everyone, but that does not mean it's impossible. So if that is what you need, then there are ways to get it. Sorry to have to leave. Looking forward to receiving the recording. Appreciate this very much. What brand is the cream? Don't know what cream you're referring to. Oh, you might be referring to my vaginal estrogen. It's called Estragyn. I don't know if this is backwards or not. Estragyn. I also use moisturize vulva and vagina with hyaluronic acid, and it's called Feel Amazing. You have just answered my question. Thank you. Okay, that's amazing. I'm going to see my doctor tomorrow. He is clueless about menopause. You don't know that. Just might not have the time to talk to you about it. But he might be clueless too. From experience, I want to leave with a prescription for hormone therapy if you need it. I am 55 and 1 year post-menopause. You do. I have vaginal dryness, joint pain, and definitely want to prevent bone loss. You definitely need it. My hope is that I can walk away with a prescription for estrogel and prometrium. That's what I take. My question is, do I also ask for Vagifem and use this suppository together with estrogel and prometrium? Answer was 100% yes. Yay. Thank you for this webinar. So helpful. My doctor will not be ready for me. I'm laughing. I'm imagining a whole generation of women changing how doctors interact with their patients. And let's be real, this isn't, okay, they didn't get hormone health training in medical school. That's a given. So we can't be mad about that. Being mad will not change things. They also can't be experts in everything. If I have the same family doctor for my children, my aging parents, like how are they supposed to know absolutely everything? And then I show up for my own health and they don't have the education, the expertise, or the experience to treat me. So what it requires is both parties to work together as a team. Someone's the goalie, someone's the forward. You're saying, listen, we know we want to score a goal. How is the best way to work together to score that goal? And I think that you have a lot of tools in your toolkit now to actually show up for that game. It's not a game, but I'm using the hockey game or the soccer game as an analogy. Yeah, sorry, I just saw that I'm muted and I don't think I'm muted because I think you're actually hearing me. Okay, I have terrible brain fog and sleep disturbances. What can I do to feel amazing? Brain fog, I want you to go through the inverted pyramid on page 25 of my book and really ask yourself some really honest questions. Is it related to how you eat and how you move? Maybe not. Is it related to sleep and the quality of sleep that you're getting? Do you have an official diagnosis of insomnia? Work with your physician on that, because sleep disruption is one of the reasons why it's at the top of the pyramid, is going to impact our brain fog. And then go through the list. It might be that you're magnesium deficient. It might be that you're iron deficient. Brain fog can show up in many different ways. You might have a thyroid condition, or it might be related to fluctuating declining progesterone and fluctuating estrogen. So depending on how old you are and the date of your last period, then we can go through those questions and prepare you for a conversation. But if it's brain fog and sleep, it sounds like you might be in perimenopause or post with declining progesterone. And I want you to get curious about whether or not you have an official diagnosis of insomnia. I'd also question what your stress levels are like, because it can impact brain fog in a big way. Ask me how I know. And while we're here, I may as well just stay and reiterate what the definitions of insomnia are to see how this lines up for you. So a definition of insomnia is any of the following: difficulty falling asleep, difficulty staying asleep, waking up too early, or having your sleep or lack of sleep disruption impacting your quality of life the following day 3 or more times a week. Any of those things 3 or more times a week. And if that's the case, you have insomnia and there are treatment options. And it is so important to prioritize sleep, because that's why it's at the top of the list. Because if we don't prioritize sleep, we're not in a good place to come to a webinar like you did tonight, or to show up at our doctor's appointment and have a really informed, confident conversation. So, and do all the other things that we have to do in our lives, and the roles and responsibilities and the people that we have to look after. Any guidance on doses for hormone therapy? No, I'm not a prescriber. I can't talk about doses. I can tell you what's in the position statement. with regards to progesterone. But other than that, it's really about working with your healthcare provider. I'm worried my doctor won't have a clue. Well, there are guidelines. So depending on what your doctor is, I can send the links to the Canadian Menopause Society, the North American Menopause Society. All the guides are there. They're all guides because hormone therapy is an individualized protocol. But when they're prescribing anything, they always refer to the guides. So what dose would I start this insomnia medication at? What dose would I start this antidepressant at? What dose would I start this hormone therapy at? They have access to all of those tools. How am I doing? How do I even begin when I don't have a family doctor? Great question. Thank you for bringing that up. There's lots of options on the menu. They might not all be easy. Yeah, somebody put Felix in here. That's a new online platform for prescribing hormone therapy. Not everyone is going to qualify because some of us have complex health situations. If you are one of those people, Felix is an online prescriber and pharmacy. Yes, the doctors and the nurse practitioners behind Felix are trained in menopause care, but they're not seeing you. They're not taking your blood pressure. They don't know your family history. So unless it's a very straightforward situation, it won't work for you. But I recommend that you go on and take the quiz and see if it's going to be a right fit. And that might be a great place to start. And thank you to the fellow member here who suggested that. If that doesn't work, there are other ways. Everything from a walk-in clinic to exploring nurse practitioners who can prescribe in your area, to naturopathic doctors. And as I said, we have so many here in Canada who are trained in menopause care, getting a referral from a walk-in clinic doctor. Like I am a dog with a bone, so I will just beat my head until we find a solution for you. And there are. It just takes work. And we can do it, and you're worth it. I have compounded testosterone cream. Do you know what a good starting dose would be? No, I don't. Unfortunately, I can't talk about doses at all. I wouldn't know, and that would be irresponsible. Thank you so much for the class. I definitely benefited. Thank you for all your hard work to provide us with the tools. I'm so happy I joined Menopause Chicks. I'm so happy you did too. And it's okay. You say you wish you had to join sooner, but it's never too late. It's never too early, and it's never too late to join Menopause Chicks. I've been prone to UTIs all my life, 49, and I've had 6 since January. Oh, dear goodness. I just about said your name. I try not to use names on here on the recording. My GP gave me estrogen and a referral to a urologist in September. I've been on estrogen for 2 weeks and it's taken away the buzzy urethra feeling. So I'm happy with that. He's also got me on an antidepressant, which took away my hot flashes. No question, I suppose, but looking forward to next week's session. Okay, I'm so glad you're coming next week. I'm so glad you have estrogen, and we'll talk about what else you can do to make sure that you do not have another UTI, or you have significantly fewer, because you deserve to feel amazing. And just a note on the antidepressant that took away your vasomotor symptoms. That is an approved non-hormone therapy approach to vasomotor symptoms, but it doesn't fix what caused the vasomotor symptoms in the first place. So that is hormone decline. So it might be worthwhile having an investigative conversation about what the benefits of hormone therapy are for you going forward. Can you recommend something for hair loss? I have done all the tests. Thyroid is okay. Dermatologist says stress. I can't handle it anymore. What is the cream that you were talking about? Yeah, so look up the brand Dercos, DERCOS, and it is owned by Vichy. And some of you will know that I have worked with Vichy for the last 6 years. They are very supportive of women's health education, and they have done extensive research in hair loss. I'm not experiencing hair loss, but I do use their products because I'm experiencing hair dryness. So they have 4 different solution focused. They are hair products, but they're not in the hair section of your local pharmacy. You can go online to vichy.ca and just learn and read more about it. But there is a hair loss protocol. And I don't know if you were the person that I spoke to a few minutes ago about this, but I do not want you to think that this is a solution. It's a bit of a Band-Aid solution, and sometimes that's okay. Band-Aids are good. They stop the bleeding. A Band-Aid solution would address the hair loss, but it won't address what's causing the hair loss in the first place. So I would still get curious. I love that you've checked your thyroid. I would be curious of what your ferritin level is, and or is there another reason why you're losing hair? Okay, how are we doing? Do we need to take progesterone, or can you just do estradiol and estrogel? No, you can't. I love that you guys like went in and went, oh, she answered it. Yeah, you can't, estrogen can't go unopposed. So if you have a uterus, you have to take progesterone. And even if you don't have a uterus, I would recommend that you have a conversation about what the benefits might be for you. Can you speak to how to get help with low sexual desire? It is killing my 30-year marriage. Yeah, absolutely. My husband is out of patience. I live in rural BC outside the Lower Mainland. I'm 61, postmenopause 2 years. Follow the work of Dr. Lori Brotto. She heads up the Sexual Health Research Institute at the University of British Columbia. Her website is loribrotto.com. I think might be drloribrotto.com. She's written 2 books. One is, they're called Better Sex Through Mindfulness. And then the second one is a guide. And she has some free meditations on her website. And then I've got a video, it's on my Instagram page, of an interview that I did with her recently. That might be helpful. There's a section on low sexual desire in here. There's a article on menopausechicks.com. If you're having trouble locating any of those or coming up with a script to talk to your healthcare provider about this, let me know and we'll work on something together. My partner and I are in therapy for this. Is an issue between us. Of course, if you want to increase sex drive, do it. But for him, our therapist has reminded us that each person's individual sexual energy is their own to deal with. You are not there to manage his sexual energy. If he was single, he would be handling it. Just because you were there does not make you responsible. No, that's absolutely right. You're responsible for your own sexual health, and women's sexual health at every age is super important. And we can talk about that more next week if you want to. We maybe can work that into the vagina dialogues on the 17th. Thank you for answering. My iron levels are fine. I don't actually do well with my iron levels are fine. I'd like to know what your ferritin level is, and I'd like to know if it's above 60. And then that might give us some clues as to where to go next in solving for hair loss, because hair loss is not just happening. It's happening for a reason. You guys are troopers. Thank you so much for sticking around. Taking estrogen patch, and took progesterone. Doctor asked me to just try 100 milligrams, did this and bled. After 1 month, went back to 200, but still bled. What would you suggest, and what is difference between vaginal bleed and uterine lining bleed? The vagina doesn't, well, I was going to say the vagina doesn't bleed. The vagina can bleed. It's skin tissue, but it would bleed from atrophy or dryness, and it probably wouldn't be like period blood. And the uterus is where that sheds a lining, of course, that we're all so familiar with. Trying to figure out if maybe it is a vaginal bleed. Okay, so I don't know how old you are, or what stage you're at, but those are key important pieces of information in this, or for when you're having your conversation with your doctor. But if you are bleeding on hormone therapy, we have to investigate what the root cause is. It can be a sign of gynecological cancer, but let's assume, well, not assume, let's just hope that it's not, but you still have to investigate. You have to investigate to rule out that, because obviously it's something that needs treatment. You're thinking that it might be a required tweak to your hormone therapy. I am too. It might be that, or it could be something else. Maybe you have a thyroid, maybe you have an infection. If you think that it's a fingernail or you have vaginal dryness or atrophy and you're bleeding, the skin tissue is bleeding from that. Those are all of the reasons. I don't know how to answer this question, except to remind you that you definitely will benefit from getting curious and investigating, if for no other reason than to rule out something serious. So please keep me posted. Thank you for answering my questions. Thank you very much for the information. Amazing. After listening to you, I'm thinking maybe I could consider hormone therapies. I have had fear that I can not even consider hormone therapies because of my history and age. Do you have any comments after reading the following? I'm not sure I can get into this tonight, or what you're copying and pasting from, but maybe we can talk about that offline if that's okay. Canadian, frustrated dealing with family doctor and endocrinologist. I joined a menopause membership in USA with an ND. One of several conflicting information is around testing. I know. So what I refer to around testing is the guidelines from the North American Menopause Society and the International Menopause Society and the International Society of Gynecologists. So testing of hormones is not required to determine a phase where someone is in their reproductive life cycle, and it's not required to determine dosing. Okay. Now, then your question is, well, why do hormone tests exist? So everyone is unique and individual, and hormone testing exists for a very important reason. The fact that you have an endocrinologist would help explain that. So thyroid is a hormone, and we use blood work to test for thyroid. My daughter has PCOS. And so her period disappeared at age 17. And at first I was like, oh, you're an athlete. Oh, it's common. You're young, blah, blah, blah. And then we started to investigate. And of course she had hormone testing, because that was part of the diagnosis and protocol required to determine whether or not she had PCOS and what the right treatment would be for her at age 17. My sister, who's 10 years older than I am, reached menopause when she was 36. You can read her story in here. When she reached menopause at 36, she had to have her hormones tested. Her health team needed to determine what they were dealing with and what the best solution would be for her going forward. Happy to say she's a healthy 67-year-old. But the point is, hormone testing exists for a reason. It's just not used by the menopause societies of the world to determine where a woman is in her cycle or what dosing or hormone therapy that she needs. So hopefully I did a good job explaining that. Let me know if you have any questions. I really enjoyed this. Thank you. But bedtime on the East Coast? Well, abso-friggin-lutely, it's bedtime. It's almost my bedtime here. Can you buy Feel Amazing on Amazon? No, it's not. It's at feelamazing.com. I think you're probably looking at a shipping cost for the small container, 30 grams. But shipping is better when you buy the 60 grams or the 90 grams. Let me know. We can talk about it. And we can talk about it more next week too. So come to the Vagina Dialogues. Thank you for the info on sexual desire. I will look into the resources, may end up checking out Sex Therapist in Vancouver. Go to my podcast, just Menopause Chicks podcast, wherever you like to listen to your favorite podcasts. And there's a great sex therapist conversation with Dr. Carolyn Klein. So you might find that interesting as well. Since menopause 6 years ago, now on transdermal estradiol and progesterone. During this 6-year period, continued increasing A1C, cholesterol, and uric acid. Is it hormone related? I don't know. I'm not your physician, but it could be. And I don't think that we touched on this today. So thank you for bringing up this part of the conversation. But as our hormones decline, the relationship to our heart health becomes super important. So when estrogen declines, blood pressure goes up and cholesterol can go up. And both of those things can be estrogen related, or they could be something else. So underlying health conditions, lifestyle, all the other things on the pyramid that we've been talking about tonight. So I don't know the exact answer to your question, but if you look at the pyramid or you take the pyramid into your next health appointment as a reference tool or as a conversation tool, it's on there. And you can work what you learned tonight into that conversation. Or if you need help preparing for that appointment, I would be happy to help you. This was wonderful. Thank you so much. You were amazing. I have to keep fighting to stop losing my hair. Yes, you do. And I will fight along beside you. How's that? We did it, and it's 6:30 on the West Coast. Thank you everyone for being here. I don't even have a wrap up. I'm just like completely overwhelmed with gratitude that so many of you signed up for this masterclass. You know, I work in the Menopause Chicks community, which is usually behind this screen most of the time, typing out responses as best I can, but you now know the value of talking it through and how there are a lot of nuances and a lot of considerations. And so it's the middle of July in a very hot summer for most of us. And you have a lot of things that are demanding of your time. I'm getting teary-eyed. There are a lot of things that are demanding of your time, and you took time to put your own name at the top of the to-do list today. So that means so much to me. And please snap a picture of your Post-it note. I want to see I deserve to feel amazing, coast to coast, across the continent. And I want you to remember that. And I don't know why I'm emotional, but I'm just really glad that you're here. Have a good night, everybody.